Good. So, where would you like to start their analysis of paranormal activity?
Yeah, so this movie scared me for sure. The one thing that was very frustrating for me was the boyfriend's response to the girlfriend.
Yeah.
And I was saying earlier on round, like part of it was like he had like very they're not even delusions. Like I don't think we can classify some delusions because he had the evidence to back up that they were real. But part of it, the reason why he kept trying to like call them a delusion is because he, if that believing that there were, he or she had a delusional disorder was almost a better rationalization than believing that like it was real, and that is why he, processed it that way. It's like there's like things, it's like he was trying to like sort of rationalize his instincts, I guess, like the superego thing, the id, by saying that like there is something else going on.
I think that to begin, I'm not so sure they aren't delusions, and it's only because of the way this particular film is shot. I mean, we literally see everything through Micah's perspective, and I have no idea if he altered any of that film, and if so, what is true, what isn't true, what he truly believes, what he doesn't. That's got to be teased out. So, trying to leave everything open and being open-minded, especially when we initially begin to discuss what's going on in this house and what's going on with Micah and others. And since he uses the D word, I mean, it's a nice place to start. And if it's going to be on an exam, a shelf exam, we may as well start there. So delusions are fixed beliefs. They're but one evidence, certainly a single criterion for a psychotic process, specifically schizophrenia and schizoaffective disorder. Not to say that Micah or anybody else has schizophrenia, but again, that's I think where the initial thoughts go. If you're asked, and I think we've already discussed this, but it's worth re-asking, what neurotransmitter is dysregulated in this very process?
Dopamine.
Too high or too low?
Too high.
Too high? And where? I don't say the brain.
And, basal ganglia.
Limbic. Oh, sorry, I didn't even let you finish.
Yeah, we were
On the same page.
Yeah.
Yeah, excess dopamine in the mesolimbic tract will result in exactly what we see happening with Micah, to the extent that we vet this and they turn out to be delusions, right? Which is certainly, I think, a valid place to start, right? Do we think that Micah is also experiencing, or anybody else, also experiencing any perceptual disturbances? And the reason why I ask is because it would be reasonable that they would, if in fact their dopamine were in fact in excess at their mesolimbic tract. Not only would we expect to see delusions, these fixed beliefs that are not reality-based, but also perceptual disturbances like hallucinations.
auditory, potentially.
Potentially, right? Potentially. So we may have a working diagnosis here. We have to continue to be very flexible and open-minded as clinicians. This might be culturally sanctioned, and there might be things going on in this house which science doesn't explain. But with the science, we're at least initially discussing that chapter in the DSM titled "The Schizophrenia Spectrum and Other Psychotic Disorders." Now, I heard delusional disorder mentioned. How might one come to the conclusion that an individual, maybe Micah, has delusional disorder and not one of these other conditions like schizophrenia or schizoaffective disorder?
If it's just one delusion or more than a lot of them, there's no other hallmarks of schizophrenia, like hallucinations, disorganized like speech, continuity.
Or negative symptoms.
Or negative symptoms, right? Yeah. So basically, just to paraphrase and rephrase, the individual will certainly present with delusions, but no other signs of dopamine excess or dopamine hypoactivity at the mesocortical tract, i.e. negative symptoms. So I think very quickly, we need to go and vet those auditory hallucinations because that might actually help us differentiate between schizophrenia and delusional disorder. If delusional disorder, and even if schizophrenia, what theme of delusion do you think might be in play here? What are the 5 themes and which one do you think is prevalent?
Jealousy, persecution, erotic, something, grandiosity and somatic.
Right? Which one, for Micah?
For some,
Been persecutory. Remind me, does either Micah or not Chrissy, Katie. Have any somatic complaints? Doesn't Katie have marks on her?
yeah, and she gets breathed.
Yeah.
Yeah, yeah. So that would be mixed type, right? It'd be mixed for Katie. But maybe persecutory then, for Micah. I mean, again, mixed for Katie, persecutory and somatic. Again, that acronym is JPEGs. Right. What else did you see? If we're gonna continue to focus on Micah, what else did you say?
I feel like Micah might have like some kind of personality disorder. I kind of thought of like antisocial, but also narcissistic. He clearly has like a disregard for Katie's feelings regarding how he's going about this. And also he has like this elevated like sense of worth or ability to enact on whatever's occurring. Let's just say that all the footage is as it actually is and it's not altered and there's some supernatural things occurring. There's experts coming in saying this is what's happening, don't do anything about it, don't do these things, and he's disregarding that. He's disregarding the Micah, who is not Micah, Katie, who like I would say knows more about it than he does, and he's doing all these interventions that's clearly making her feel poor about everything, and he doesn't care. So that's why I think also where the antisocial comes in. He doesn't really care about her feelings or her safety or her mental state, and he just has this savior complex, if you will, or he thinks it's a game and he's just doing whatever he wants with it. So I feel like there's a little bit of both in that.
But what about if somebody countered that with, if this were to be uploaded to YouTube, they're gonna be millionaires.
So then I'd still go back to antisocial because he doesn't really care about how it's affecting his wife.
$1 million.
That is a lot of money though.
Well, but what happens if he does care because he's gonna bang her flowers until the last flowers set on their graves? It's a lot of money. That was romantic.
To that end though, so I know the movie's supposed to be scary. I was frustrated the entire time because I know we were just talking about how we feel about patients and their presentation is really irrelevant, but I was very frustrated at his behavior the entire time. Just exactly as you're saying, what if he gets $1 million out of this? I think narcissistic personality disorder has an aspect of exploiting others for gain, which Katie clearly is getting the short end of the stick. If we're taking these, like the demon essentially to be real, if this is actually happening to her, she's obviously getting tortured. She's obviously very scared. He doesn't care. So it's that lack of empathy component. But I feel like almost there's a layer of exploitation as well. If potentially he were to upload this to YouTube and get something out of it. I also found throughout this whole process, like the number of times she says, Micah, please, in this movie and wants him to stop doing what he's doing, is almost like too many to count. And every time she criticizes him, he reacts with immediate defensiveness. And he has this really fragile sense of self, which I think is also corresponding with the narcissistic personality disorder.
So let's talk about this a little further. I mean, and I don't put words in your mouth, but your countertransference was inconsistent with there being a payout for this couple. Because if you truly felt that, hey, I'm going to become a millionaire, and this is you countertransference through Katie. I don't know if frustrated would have been the word you used. So you're picking up on something else going on other than there being a cash cow at the end of this, some payout at the end of this. That's what you might have been tapping into. And if there was, I'm hearing that you're thinking that it may not be equitable. Michael might be rolling in it, but I'm not so sure Katie would be. You might be picking up on that. And along those lines, let's continue this conversation. All the personality disorders, and let me, and this is, we're not on camera. So this is a raise of hands and a raise of hands only. If I were to provide a challenge to the people around this table, if you could name me all the personality disorders right now, and if Dr. Terragino's listening along, this is not real. So please don't forward this to Dean Murtha, but if you were to name all the personality disorders, instant honors for your psychiatry clerkship, don't even have to sit for the shelf exam. However, you've missed one, you got to remediate your M2. Now, I think I'll talk to the Office of Education. You will not need to pay for it. It'll be free. But you will need to remediate your entire M2 year. Raise of hands only. Who takes that challenge? Huh? It's not arrogance, it's easy. It's an easy honors. All right, so offline, we'll talk a little bit about this, right? Not Robert Wood, but we'll talk about how the next time I ask that question, that hand's gonna fly up so fast. We're all gonna take notice, right? So we'll do that offline. Just remind me at the conclusion of our recording. When you study the personality disorders, I want you to do it in 2 tiers for your shelf exam. Do it traditionally, do it according to 3 clusters, do it the way the American Psychiatric Association has organized it for you. After you went through that once or twice, I want you to reorganize the classification system. I want you to instead create 2 columns. Column 1 are a list of the disorders in that chapter, and please don't look that chapter up just yet. Not that I'm pointing fingers. Column 1 will be all those conditions that actually adhere to a cardinal trait. All right, we're going to discuss those cardinal traits right now. Because once you understand the cardinal trait, when you then review, again, for the 3rd time, the definitions of each of these conditions, all those traits instantly morph into examples of that cardinal feature. And it becomes a lot easier to identify on a shelf exam. Of course, the other column, and there really is only one cutting into the chase, it's called borderline personality disorder, that does not easily fit into a cardinal feature. That one you're going to have to dedicate a little bit more time to, but that's okay because that's the one that's most likely to appear on exams anyway. So you're going to want to dedicate the time in preparing for your shelf, right? If you take that 2-step process, learn it the way an average medical student does, and then do it the Robert Wood way. Reorganize in your mind 2 columns instead of 3 clusters. Those that actually adhere to a cardinal trait versus those that do not. You'll be set for the shelf exam, no problem whatsoever. All right, now let's actually take this conversation and begin to point to that cluster B personality. All right, I heard narcissistic, and I heard antisocial. The good news here is that both are in that first column. Both narcissistic personality disorder as well as antisocial personality disorder, in fact, do adhere to a single cardinal trait. So I'm going to ask you, do you feel Micah has a blatant disregard for and violation of others' rights?
Yeah.
All right, then he fits the cardinal trait. Would think of it as a screening for antisocial personality disorder, right? Now, not that we're going to do it here. I think it's a little bit beyond the scope of our discussion. This is where you pull out your pocket DSM and you review those diagnostic criteria, of which the individual, Micah, would only need 3. Low threshold here, 3, to rule it. Let's say, for discussion's sake, the answer is yes. That in reviewing the DSM criteria set, Micah does reach that threshold of at least 3. There's one more thing to consider here. That is specific to antisocial personality disorder. What is it?
Did you have conduct disorder?
Exactly right, right? Do we have any evidence one way or the other in this film? We don't. So if the answer is no, there's no evidence, it means that it's still open for discussion, right? Which means we got to talk to his mom and dad, former teachers, collaterals. But that's the way I would process that. Second question. Is Micah arrogant? Does he believe he's special and could only be understood by people as special as he is? Yeah, okay, that pause is probably a collective no, right? Probably not, which means that he is not meeting criteria for narcissistic person. He doesn't meet the cardinal trait anyway. Now, if you think, I'm on the edge, then go through the diagnostic criteria anyway, right? If you think the screen is equivocal in some way, sure, spend the extra 2 minutes and looking through that symptom set. In this case, I believe he would need 5 total from that. And again, he may or may not, right? But that's the general kind of approach. And you do the same thing for borderline, you do the same thing for the histrionic personality as well to conclude the cluster B personality disorders, right? So it looks like he's ruling in for antisocial personality. We do want to investigate whether or not he has evidence of conduct prior to the age of 15, probably not on the narcissistic side. Maybe he has some narcissistic features,
Yeah.
but because these conditions cluster, we might be able to attribute them to the antisocial personality if in fact he goes in for that. Right. Makes sense? All right, and you do the same thing for cluster A, same thing for cluster C in terms of studying for your self-exam. There are other things we have to consider, and we'll pull back a little bit and talk about the general approach to assessing personality, right? There are about 5 things that the investigator must consider before they assign a personality disorder. That is, before we actually relay that what's going on is who you are, and your traits have been crystallized in a maladaptive form that results in clinically significant distress or impairment. What are those conditions? I just gave you one. It has to be clinically significant. Like any other mental disorder, personality disorders must be clinically significant. Any personality disorder must result in clinically significant distress or impairment in functioning. That's definitely one. What are some others that we have to, that are universal across all these conditions? Good,
They're part of who they are.
right, they're stable.
Can
Right.
other people see?
That's true, but it's not required as a,
Adolescents. That it starts early.
that's part of stability. Yeah, that's part of it being stable longitudinally. But-
I was gonna say, some of the effects of like disrupting personal relationships.
So that's part of clinical significance. We got that one.
Not due to a substance.
Good. Good,
Or other psychiatric conditions.
good. Right, can't be doing it to another psychiatric condition. So if they're in an acute manic state, if they're in an acute psychotic episode, you have to be careful to render judgment on who they are as a person, for better or for worse. One more, 2 more. At any one point in time, it must cross multiple social settings, right? So if a particular person is a really crappy antisocial course director, but once outside the hospital, he is a quote unquote different person. We're not talking antisocial personality, sorry, we're talking a crappy course director. So it must be stable over time, but at any one point in time, it should cross social situations. And the final one, which I think you intuitively understood and just skipped over because it's so obvious, it can't be due to an underlying medical condition. And so those are the 6, and they're applied and they're applicable to all of the personality disorders. All right, so I'm a little concerned about Micah. I mean, you told me he's delusional, or we have that as a working diagnosis anyway. I don't think our next step should be to draw a conclusion on who he is as a person, antisocial, narcissistic, or otherwise. So I'm going to defer access to, or what used to be called access to, I'm going to defer my diagnosis on any personality disorders until I can get his primary issue, I think, addressed and treated, whatever that condition might be. Other thoughts here? Is there a middle ground? Is there, I mean, we're kind of looking at this as a dualistic scenario. It's supernatural versus it's not. Is there a middle ground where it's both supernatural and he is psychotic? And how might that kind of align?
Would you, sorry, just to clarify, as like if we had a patient come in, would we ever consider a supernatural claim as legitimate?
Probably not in a slice of time. I think the medical profession's a little too scientific. Right. Although I think one thread that we'd have to consider that cuts across everything would be cultural relevance and what is culturally sanctioned. There we could then on a case-by-case basis say that this is something that the particular culture sanctions and therefore for this individual is normal behavior. That is true. But I don't think we can actually do that in terms of a programmatic way to look at things and say, well, this is the chapter of the DSM that has not yet been written called the supernatural or necromancy. This belongs here. I'm not sure we're ready for that.
That reminds me of, when I was at EBHC, working with Dr. Fatika. And we had this one, we were talking about hallucinations, and I asked the patient, like, have you ever had hallucinations? And he's like, don't ask that, because all of them believe that it's real. So then, shortly after that, we saw a patient who was schizophrenic, and he has his hallucinations, but he knows they're hallucinations. And he knows they're not there. He knows that he's hearing things that other people aren't hearing when they're happening. So then he also said, like, I think they're demons. So then Dr. Pratika said, oh, so I'm like, he knows that they're not actually there. Would that count for you as a hallucination? And he's like, well, yes, because he believes it's a demon. And then, when you bring that up, it reminds me of that, because I mean, obviously, in this case, this patient is psychotic, obviously, but like cultural relevant, like Christians believe in demons, right? So then it's like, could you say, you know what I mean? It's like it became a little bit ambiguous there, and that obviously he was schizophrenic and hearing things that weren't there, but like, could you call it delusion if it's like part of your religion to believe that this thing occurs and that other people believe that these things occur?
Yeah, and I'll complicate, I guess a great point, and I'm gonna actually complicate it just a little bit more. Up until 2013, when, and again, we'll keep this fictional, when there'd be a person like Katie, who presents at the end of this movie, if, you know, after she does what she does with Micah, she, you know, tosses Micah's body into the bedroom, walks down the stairs across the acute psychiatric services, and you're on call. Okay?
Oh.
I've gone attending.
So I'm on call. Up until 2013, I'd be like, hey, this is pretty cool, because metaphorically, we could talk about this as a case of DID, right? Where that dissociative alter happens to be the beast, or Toby, depending on how far you got into this genre, this particular franchise, goes by different names, right? In 2013, that changes, right? With the revision of the DSM to number 5, the APA tweaks the definition of DID, where the individual experiences a distinct personality state that takes over the conscious awareness. And that personality state could be experienced as a form of possession. So the P word is actually in the definition now of DID. So that's something that we have to address, right? Now, my thinking as a Christian clinician is that the line to cross is always when there's clinical significance. So when someone who's devout in their belief that demons exist tell you that they are now possessed and it's causing them clinically significant distress or impairment in whatever voices are coming out of them, then we have to treat them in my role as a psychiatrist. Saying it's culturally sanctioned is one thing, but when it's causing my patient distress, I still have to act like a doctor.
So just, you know, out of curiosity, if like a patient said that they really want an exorcism, and I feel that's kind of cultural, right? That is like their religious beliefs and the cultural. Would that be something as like a medical service we would extend?
Yeah.
Yeah.
Re-ask that question when we stop streaming, because that happened. And I'll give you how the CL service handle that, and yeah.
I had that same question.
So if you forget to ask, you'll remember. We'll address that. When we cut off the stream.
Yeah.
Just want to turn off the lights. Other thoughts about Micah?
I thought his persistence on being in control was interesting because the you know, Katie kept saying we should call somebody in, and despite his beliefs or not beliefs or delusions, he said no, I'll control it, and he would go to these tasks, but he also wouldn't call in a higher authority to kind of assist him, which I thought was interesting given that situation.
Yeah, again, that could be consistent with his neglecting the safety of others, or as well as himself. Certainly. And that would continue our discussion of personality disorder.
So in the event he didn't have conduct disorder, where you,
Yeah, so let's say that Micah does, and again, we have a validated and reliable source that tells us there's no evidence of conduct prior to the age of 15. Mom, dad, sister, everybody's on board. There's no way we could come up with that diagnosis. And let's also say that upon further investigation, there's no evidence of a primary psychotic process, mania, etc. That is, there's not another mental disorder leading us to have to discuss a personality disorder. Right, so I want to get us in that clinical space. And ask, well, what does one do, either generally speaking or pertaining to this character, Micah, when it looks like it is antisocial personality disorder, perhaps it's even textbook antisocial personality, but missing conduct, what then? And I think most of us would default to this idea of psychopathy. Right, so
Psychopath.
Yeah.
To be clear.
Yeah.
So in this situation, let's say Micah comes into the hospital and he comes with Katie. And he is having something we assume is a delusional disorder, but Katie's also corroborating it in her situation. I feel, would that present a difficult situation into deciding what is delusional, or if their delusional disorder is interconnected
Yeah.
in their interpersonal relationship?
Yeah. So
And also the sister-
yeah,
the
yeah,
sister as well.
that's where I would start. Yeah, Chrissy and Chrissy's dead husband and Hunter. So I think if we're continuing down this road of a primary psychotic process, rule out delusional disorder versus schizophrenia or another psychotic disorder, and now we have Katie there as well. I want to know how long have you been together? When did it start and who did it start? And the other person, when did it start? How did it start? Because I'm working up the process of shared psychotic disorder, fully ado. And just as importantly, when when Katie goes away on work and she's away for a week, do the symptoms strengthen or do they weaken? Because we'd expect them to weaken if this is due to shared psychotic
Or
disorder.
if they're weakening because when she's like haunted.
That's the idea.
Yeah, well, again, we have to always respect what is culturally sanctioned. But again, as a psychiatrist, I think our primary focus is going to be on the clinically significant behavioral change. And if we're thinking psychosis, we're thinking shared psychosis in the other character here. That's the idea. Now, again, Katie presents with some symptoms that are atypical. That is, they are different from Micah's. So even though we might start with, he has a delusion, now you have it. When we do kind of tease out this timeline, just for discussion's sake, it looks like it started X number of weeks ago with Micah, and then 2-3 weeks later for you, pointing to Micah being the primary case. This is really shaping up like shared psychotic disorder, like Foley do. However, I also have evidence, and it's on camera, that Katie has a distinct personality state that takes over a conscious awareness. That does not happen to Micah. So there's something going on that is inherent and specific to this character, that is Katie, that does not point to Micah as being the proband. And that might be DID. Right. And I think we're kind of tipped off about that when she has a dissociative episode that results in amnesia. Right? She's having that swing. And Micah calls her catatonic, which basically said that she's unresponsive. She's not responding to him. The morning after, she attests, confirms that she has amnesia. She doesn't remember going out there or coming back. Right. So the question I have, and I would have at that time, is what caused the amnesia? Number one, again, just like any mental disorder, direct physiologic effects of a substance or a medical condition. If the answer is no and no, we're dealing with dissociative amnesia. And is that because of dissociative amnesia, the diagnosis, or that due to there being a distinct personality state that took over a conscious awareness, resulting in that gap of time, that loss of memory, right? So that's where this is headed. And of course, we get our answer in the final scene.
with regard to a shared delusion, each person, is it kind of like on his own recessive condition where each person has it, they come together and they have this delusion, like they have something underlying? Or is it just like, I'm just wondering like how the delusion, do they already have like something predisposing them to having delusion?
We always have stuff predisposing us to everything. Right, so let's just be very general about that. In the case of shared psychotic disorder, there is always an individual that is an index case. And it usually goes from an individual who is at some position of strength to someone who is submissive in some way. So it's usually parent to child. That's the transmission we often see as a quote unquote social contagion. Or a psychological contagion. That's what usually happens.
That's similar to what happens in cults.
Yeah.
like the-
Yeah. Yeah. Now, while delusions are quite common in this, what is less common are perceptual disturbances. So when we start hearing that Katie has a shared experience when it comes to the hallucinations too, it could happen with shared psychosis, but we have to really investigate alternative reasons for her having those perceptual disturbances because it's rare. Certainly less, more rare, less often, less prevalent than the delusions being shared. Is it the new Joker?
Yeah.
Subtitle Folia do?
Fully do.
Yeah, cult, again, cultist. Of course, they didn't make her a shrink, right?
She's not? Lady Gaga? I thought she was part of the.
Isn't she a psychiatrist?
Yeah.
Harley's a psychiatrist.
Yeah. Oh, you said she wasn't a shrink.
But I said they had to make her a
Yeah,
shrink.
she-
Final thoughts?
I'm scared.
One quick promo, if you're interested, check out our blog on the 31 Nights of Halloween thread on Reddit. We have some of these ideas up there. Please comment on them. We have a movie for each of the 31 Nights of Halloween. So visit us, comment, be looking forward to your comments, and we have a bunch of undergraduate interns that will respond to your comments too. So if you're interested, keep that conversation going. All right, we're good. Thank you.